Golden notes: celiac disease, caused by sensitivity to the protein gluten due to T cell mediated hypersensitivity reaction. Mechanism: repeated protein gluten exposure, villus atrophy, then malabsorption. So it is an inflammatory disorder of the small bowel occurring in genetically susceptible individuals, which results from intolerance to wheat gluten and similar proteins found in rye, barley, and to a lesser extent oats. It can result in malabsorption and response to a gluten-free diet. The condition occurs worldwide, but is more common in Northern Europe. The prevalence in the UK is approximately 1%, although 50% of these people are asymptomatic. These include both undiagnosed silent cases of the disease and cases of latent celiac disease, genetically susceptible people who may later develop clinical celiac disease. And in pathophysiology, the precise mechanism of mucosal damage is unclear, but immunological responses to gluten play a key role. There is actually a strong genetic component, with around 10% of first-degree relatives of an index case affected, and there is strong approximately 75% concordance in monozygotic twins. There is a strong association with the human leukocyte antigen HLA DQ2 or DQ8. So the conditions associated with celiac disease include dermatitis herpetiformis, a vesicular pruritic skin eruption, and autoimmune disorders, type 1 diabetes mellitus, and autoimmune hepatitis. It is strongly associated with HLA-DQ2, 95% of patients, and a question may be about this point, and HLA-B8, 80%, as well as HLA-DR3 and HLA-DR7. The prevalence of celiac disease in Europe between 1 to 100 and 1 to 300. And this is also a point that should be considered. It presents at any age, but in adults, the commonest age of presentation is 20s and 30s. You should note that women are slightly more commonly affected. The action of tissue transglutaminase on alpha-gliadin generates epitopes to CD4 T lymphocytes, which provoke an inflammatory response in the intestinal wall. The clinical picture would be diarrhea, oral aphthous ulcer, weight loss, growth retardation, general malaise, neurological symptoms, ataxia, weakness, and paresthesia, abdominal pain, amenorrhea. Complication could be anemia, folate, B12 or iron deficiency, increased malignancy, hyposplenism, dermatitis herpetiformis, it's an itchy rash, improves with dapsone, osteomalacia, abnormal liver function tests. So remember that celiac disease can present at any age. In infancy, it occurs after waning on to cereals and typically presents with diarrhea, malabsorption, and failure to thrive. In older children, it may present with non-specific features such as delayed growth. Features of malnutrition are found on examination, and mild abdominal distension may be present. Affected children have growth and pubertal delay, leading to short stature in adulthood. So in adults, the disease usually presents during the third or fourth decades, and females are affected twice as often as males. The presentation is highly variable depending on the severity and extent of small bowel involvement. Some have florid malabsorption, while others develop nonspecific symptoms such as tiredness. weight loss, folate deficiency, or iron deficiency anemia. Other representations include oral ulceration, dyspepsia, and bloating. Unrecognized celiac disease is associated with mild undernutrition and osteoporosis. Celiac disease is associated with other HLA-linked autoimmune disorders and certain other diseases like type 1 diabetes mellitus, thyroid disease, primary biliary cirrhosis, Sjögren's syndrome, immunoglobulin A deficiency, pernicious anemia, sarcoidosis, dermatitis herpetiformis, and small bowel carcinoma, and others. Investigations. In fact, diagnosis is made by a combination of immunology and jejunal biopsy. Villus atrophy and immunology normally reverses on a gluten-free diet. If patients are already taking a gluten-free diet, they should be asked, if possible, to reintroduce gluten for at least 6 weeks prior to testing. Tissue transglutaminase (TTG) antibodies (IgA) are the first choice. In fact, selective IgA deficiency is more common in patients with celiac disease. For this reason, IgA levels should be checked when serological tests are ordered. If the patient has selective IgA deficiency, then tissue transglutaminase (IgG) can be measured. Patients normally need to be following a gluten-free diet for at least 6 months before the serology becomes negative. Endomysial antibody IgA, 90% sensitive and almost 100% specific. Anti-endomysial antibodies are sensitive and specific but miss the disease in about 5% of the population who are IgA deficient. Anti-gliadin antibodies, IgA or IgG tests are not recommended by NICE. Anti-casein antibodies are also found in some patients. Duodenal biopsy are the gold standard for diagnosis. Villus atrophy, crypt hyperplasia, increase in intraepithelial lymphocytes, lamina propria infiltration with lymphocytes. Appearances may resemble severe tropical spure. In fact, subtotal villus atrophy is seen in a number of conditions other than celiac disease, such as severe tropical spure, cow's milk or soya sensitivity in children, gastroenteritis, Whipple's disease, hypogammaglobulinemia, neomycin therapy, laxative abuse, Norwalk agent. Now, other investigations imaging abdominal radiograph with barium contrast can see decreased jejunal folds and increased ileal folds. The management, gluten-free diet. Gluten-containing cereals include wheat, like bread, pasta, barley, like beer. In fact, whiskey is made using malted barley. Proteins such as gluten are, however, removed during the distillation process, making it safe to drink for patients with celiac disease. Rye, oats. Some notable foods which are gluten-free include rice, potatoes, and corn, and maize. Now the follow-up, tissue transglutaminase antibodies may be checked to check compliance with a gluten-free diet. So, in the management, the aims are to correct existing deficiencies of micronutrients such as iron, folate, calcium, and/or vitamin D, and to achieve mucosal healing through a lifelong gluten-free diet This requires the exclusion of wheat, rye, barley, and initially oats. Although oats may be reintroduced safely in most patients after 6 to 12 months. Initially, frequent dietary counseling is required to make sure that the diet is being observed, as the most common reason for failure to improve with dietary treatment is accidental or unrecognized gluten ingestion. Mineral and vitamin supplements are also given when indicated, but are seldom necessary when a strict gluten-free diet is adhered to. Patients should be followed up after initiation of gluten-free diet with assessment of symptoms, weight, and nutritional status, and blood should be taken for measurement of TTG or anti-endometrial antibodies. There are currently no additional non-invasive tests to assess small bowel mucosal healing. Repeat small bowel biopsies are not required routinely, but should be considered in patients whose symptoms fail to improve and those whom antibody levels remain high. In fact, there remain a small number of patients who fail to respond adequately to a gluten-free diet, and they require therapy with glucocorticoids or immunosuppressive drugs. Associations and complications. If the patient is still asymptomatic, despite being compliant with a gluten-free diet, we should also think about T-cell lymphoma, recurrent mouth ulcers, hyposplenism, selective IgA deficiencies. Small bowel ulceration is associated with ulcerating jejunitis, but not colonic or gastric ulcers. In fact, there is a question from past papers saying that why do patients with celiac disease require regular immunization? Because of functional hyposplenism. This was provided by the SSSM Study Smart Series for Mrcp, your easy way to easy pass. Remember that the golden notes sources are Davidson, Oxford Handbook Series, Essential Revision Notes for Mrcp, and Notes and Notes. Don't forget to follow us on Facebook, Telegram, and YouTube channel. And remember, with SSSM, you're always in a safe zone and you're always the winner.